evening to everyone. On behalf of Association for Veterinary Dermatology India and INTAS Animal Health, we welcome all of you for this dermatology webinar. Today we are going to see about the diagnostic approaches in veterinary dermatology. I welcome the speaker, Dr. Vinu David, who is a faculty in Pookode Veterinary College, and he is having a lot of interest in dermatology diagnosis and treatment, and he is having separate interest in dermatology, and he is the right person to deal with this topic. I welcome you, sir. And apart from that, I also welcome Dr. Nitin Bhatia and his colleague Dr. Amanjot Singh for wonderful cooperation to run this show. Thank you very much. And any diagnosis, see, whenever you have a problem, it is very important to go for systematic approach in dermatology, particularly starting from the patient data, history, and also clinical examination. See, after that, we have to confirm the disease. Once you are going to have a suspicion, this could be the disease, like that, by way of distribution or pattern of lesion, we are going to identify, and we have some clue about the disease. This may be the disease, like that. For that, you have to confirm it. So confirmation and differential diagnosis is so important to go for a proper treatment and early cure of the disease, and also to tell the prognosis to the owner. So in that way, the diagnosis is so important and diagnostic techniques are so important. That's why we have opted this topic today. Thank you, and I request our Dr. Nitin Bhatia to say a few words about our guest speaker. Thank you.
Good evening to all our learned viewers, participants, and good evening to Dr. David and Dr. Nagaraj. My job has been made easy by Dr. Nagaraj, already touching on the major points. Yes, diagnosis is very important because here we are going to diagnose dermatological infection and accordingly going to start our treatment. To start our treatment, we need to have an effective diagnosis, for which we have Dr. David with us. Dr. David, as known to many of us, is a graduate and a postgraduate from Kerala. He is 1996 batch, after which he has undertaken a number of jobs in the field level. So he is a mix of a good field veterinarian and a good academician. He has been a teaching assistant, research associate, field veterinarian, district epidemiologist, and later to that he joined Pookode Veterinary College. He has done his PhD from Bangalore, and most of his works go around the topic of dermatology. So I'll not keep anyone waiting, and we'll just start with the session from Dr. David on dermatological diagnosis. Over to David, sir.
Good evening, one and all. I think this is a great privilege for me to address all of you as a part of this webinar, and I would like to thank Dr. Nagarajan sir, President, Association of Veterinary Dermatologists India, Dr. Nitin Bhatia, Vice President, INTAS Animal Division, Dr. Amanjot, his colleague in INTAS, for giving me this opportunity. I know that you all are knowledgeable and well-experienced practitioners. Still, I request you to consider this as a humble effort from my side to shed more light into this field. I welcome all of you to this session, and I am sharing my PPT. Sir, is it visible?
Yeah, all good to go.
Okay, sir. So today my topic of discussion is diagnostic approaches in small animal dermatology. And each dermatological case is just like a jigsaw puzzle, which consists of major pieces, especially history, clinical science, lab tests, and diagnostic procedures. So you have to gather information from all these aspects, you have to review it properly, and you have to ascertain or reach a definitive diagnosis for a perfect treatment. So a combination of all these factors are essential for a proper diagnosis. Then there are basically two types of lesions in each dermatological case. One is primary lesion, which is directly associated with the disease process. It is not pathognomonic, but it will give a clue to the disease process. And this includes various conditions like macule, papule, nodule, plaque, tumor, pustule, vesicle, wheal, cyst, etc. So these are all primary lesions which are directly associated with the disease, but they are not pathognomonic. And by the time the patient is brought to our hospital, most of the time these primary lesions would have been converted to secondary lesions due to the time or due to degree of insult, etc. The animal might have been showing itching, pruritus, etc. And all these primary lesions might have been changed to secondary lesions. So by the time the patient is brought to our clinic or hospital, the animal may be showing most of the secondary lesions of dermatology, like comedones. Comedones are nothing but blocked follicles, scales, crusts. Crusts are nothing but dried exudates, erythema, erosions, ulcers, fistulations, excoriation, fissures, lichenification means thickening of skin, and hyperpigmentation, hypopigmentation, scar, etc. So all these secondary lesions are a result of trauma, time, and degree of insult. And these primary lesions will subsequently evolve into secondary lesions. And these secondary lesions are much less specific than the primary lesions. So today we are going to discuss on various dermatological conditions like dermatophytosis, sarcoptic mange, demodicosis, Pyoderma, pyotraumatic dermatitis, Malassezia, flea allergy dermatitis, canine atopic dermatitis, cutaneous adverse food reactions, and feline skin fragility syndrome. So we will move one by one. And first one is dermatophytosis. As you all know, it's a disease condition caused by a dermatophyte group of fungi, namely Mycosporon, Trichophyton, and Epidermophyton. And signs can be highly variable and diagnostically misleading. So this is actually a pleomorphic disease where you cannot diagnose this condition by simply looking at the clinical signs. Like human dermatophytosis, the circular crusting lesions as seen in the picture may be seen in dogs with superficial pyoderma also. So this type of confusing images will create a problem in diagnosing dermatophytosis. And at the opposite, diffuse scaling and crusting, which is a typical lesion of conditions like allergy or atopic dermatitis, may be seen occasionally in dermatophytosis also. So these dermatophytosis clinical signs are highly variable and it is very difficult to diagnose it by clinical signs alone. In typical dermatophytosis, pruritus may be variable. That means it can be low or absent. Generally, the pruritus is very low in dermatophyte conditions. And a typical dermatophyte lesion is a focal or multifocal area of alopecia with broken hairs at the periphery, and the lesion will heal centrally and it will extend centrifugally. So the healing part will be in the center and the spreading part will be towards the periphery, and you can see a lesion in this picture which will mimic a case of superficial pyoderma. So all these clinical signs may mimic other disease conditions, and we have to differentiate these from other dermatological problems. So many types of manifestations are there in dermatophytosis. As you can see, a nodular type of lesion is there in the initial picture, then scaly, crusty lesions are there, then simply alopecic areas are there. So different manifestations will create a confusion, and the possibility of dermatophytosis is frequently ruled out when it occurs in a form other than the classical one. So that is the problem. It's not usually seen in the classical form, and you have to rule out whether this is a condition of dermatophytosis or whether it is a condition of atopy or a pyoderma. And fungal cultures should always be done when in doubt. When it is a classical dermatophytosis, you will get a definitive diagnosis by clinical signs or by examination of the skin scrapings. But when it is not a classical form, it is very difficult to diagnose these conditions from the clinical signs, and you have to go for a fungal culture. Now, the different techniques that can be employed for diagnosis of dermatophytosis is: one is a direct microscopy examination. Here, the broken hairs or crust can be collected by plucking or by scraping. You can suspend it in 10% KOH or lactophenol cotton blue. You can break up the crust. Either you can warm the slide or keep it as such. Place a cover slip and then examine. You can see the fungal spores very clearly in that picture. And another is here a normal hair is shown along with a dermatophyte infected hair. So the normal hair is there are no arthrospores or no fungal spores are seen, whereas in infected hair you can clearly see that the fungal spores are towards the border of the hair or outside the hair shaft. Usually it's an ectothrix type of arrangement is seen in this type of dermatophytic conditions. And direct examination of hairs and scales scraped and plucked from lesions and mounted in mineral oil can confirm lesions in more than 85% of cases where the clearing agents are not needed. In this case, you can directly scrape or pluck and keep it in mineral oil and you can examine. There is no need of KOH or other clearing agents, and that is confirmatory in almost 85% of cases. So that is very easy to do. Then skin biopsy is not indicated in routine dermatophytic diagnosis, but it can be used when there is a nodular type of lesion, especially a chirion type of lesion, or when there is any unusual presentation of the disease, you have to go for a skin biopsy. Then cytology can also be used, especially cytology of the impression smears can be used to diagnose a dermatophyte condition. Sometimes, especially when a dermatophyte condition is associated with purulent lesions, furuncles. Usually, these furuncles get infected by bacteria, but in certain dermatophytes can also cause infection of the furuncles. And in such cases, the examination of stained smears, preferably a diffuse stain, may indicate dermatophytosis due to the presence of degenerate neutrophils, macrophages, and lymphocytes in the smear without any bacteria. So there will be inflammatory changes in the smear upon staining, but there will not be a presence of bacteria in that smear. So in that case, you have to suspect a dermatophyte infection. Then fungal culture, as earlier told, is the gold standard for the diagnosis of dermatophytosis. But only thing is that prior to the collection of samples, you have to spray 70% alcohol at the site in order to reduce the load of contaminants. And the ideal culture medium is a dermatophyte test medium, and which is a very convenient method. And the DTM bottle should not be completely closed as the growth of dermatophytes is aerobic. So even though chance of contamination will be there, it should not be completely closed. And a growth of flat white colonies producing a red color in the surrounding medium means there will be a production of protein metabolites which changes the phenol red into red color within 10 to 14 days, and it will suggest the presence of a dermatophyte. So it is very easy to diagnose a dermatophyte in a dermatophyte test medium. So this is the picture shown from my PG work actually. So this is the dermatophyte test medium on the right side. You can see a trichophyton mendogrophytes culture, a white fluffy growth in a dermatophyte test medium, and beneath that you can see a cigar shaped macroconidia, which is typical of trichophyton mendogrophytes. In my study, I could get only two types of dermatophytes. One is trichophyton mendogrophytes and the other on the left side is Microsporum gypsum. Even though textbooks and many literatures are saying that almost 70% of dermatophytosis are caused by Microsporum canis, in my study I could not get any, whereas I could get only Microsporum gypsum and trichophyton mendogrophytes. Microsporum gypsum is a powdery type of colony, and the macroconidia beneath shown is ellipsoidal or spindle-shaped macroconidia can be seen, which is actually stained by lactophenol cotton blue. So there is another technique for sampling in case of dermatophytosis without any clinical lesions. Sometimes you have to screen the animal or you have to search for the presence of carrier animals. In that case, you can use a sterile toothbrush, and the technique was developed by McKenzie. It's called as McKenzie brush technique, and it's used for a screening of dermatophytes when characteristic lesions are absent on the skin. So you can search for carriers or identify the residual infection. So this is a very effective method of sampling apart from hair plucking or skin scraping, etc. Then biopsy can also be employed for a certain type of lesions, as I earlier told, like chirions and other things. You can go for a biopsy, and you can special stains like periodic acid shift stains can be used to identify the dermatophyte elements. So biopsy can also be rarely employed for the diagnosis. Another tool is a wood slab. As you all know, it's a very limited tool. Actually, you can identify only Microsporum canis infections, and that too only 50% of cases can be diagnosed. In that case, it will show apple green color fluorescence in a dark room. But care should be taken that the lamp should be warmed well before the usage. Otherwise, you will not get the proper result. And you should examine it in a dark room. Now, regarding the therapy, a combination of topical and systemic therapy is always ideal to treat dermatophytosis. And another small point you have to note is clipping the hairs at the affected area or lesion should be initiated only after starting the therapy, because otherwise you will be spreading the lesion initially and then it will be difficult to treat. So initially you start the therapy and then clip the area. Topical agents include micronazole, clotimazole, lot of agents are there. Then chlorhexidine shampoo, which is an antiseptic compound, is also effective for dermatophytosis with more than 2% concentration. So a combination of micronazole, chlorhexidine is ideal. Then in my work, I have tried an indigenous preparation of cinnamon leaf oil. 5% cinnamon leaf oil in glycerin was found to be much more effective than all these azole compounds and other allopathic compounds. It was having the highest success rate in my work. So you can go for 5% cinnamon leaf oil in glycerin topically for approximately 20 days. There are various systemic agents also. The primary agent of choice is griseofulvin. It can be used at a dose rate of 25 to 50 mg per kg body weight. It should be used along with some vegetable oils or essential fatty acids, veterinary supplements, so that it will be easily absorbed. Ketoconazole, even though slight hepatotoxicity is reported, that can be tried at a dose rate of 10 mg per kg body weight daily. Itraconazole, which is much less toxic nowadays, is very frequently used at the rate of 5 to 10 mg per kg daily. And the thing is that therapy must be continued even after clinical recovery and negative culture results. Actually, you should continue the therapy for 1 to 2 weeks more, even after a clinical recovery and even after a negative culture result. In many cases, we are not following this treatment regime. Actually, we will be stopping immediately when the culture becomes negative. But the literature says that you have to continue it for 1 week more than the sudden stoppage of treatment. Then another condition is sarcoptic mange, which is also very common. The thing is, the symptoms and lesions are more subtle nowadays because the animals are groomed daily by the clients, or parasiticides are frequently applied and they are well maintained in most cases. So a severe form of sarcoptic mange may not be seen in many cases, but in other animals which are not well groomed, the lesions are very severe and there will be constant pruritus leading to extensive erosions. And the main area affected are the limbs are affected, ears are affected, ventral neck, abdomen, all these inner thigh region, all these sides are most commonly affected by sarcoptic mange. And the typical primary lesion is a crusted papule and secondary lesion is an excoriation. So in sarcoptic mange, crusted papule is the primary lesion and excoriations are the secondary lesions, and lesions are mainly distributed on the margin of the ear and bony prominences, especially elbow and hock. So margins of the ear and bony prominences like elbow and hock are more commonly affected in sarcoptic mange. And history reveals partial previous response to corticosteroid or parasiticidal therapy. So the owner might have given some corticosteroids initially because of the severe itching, and the animal might have showed a 40% or 50% response, and the owner might tell us that initially I have given this tab, some steroidal tab, he will tell it has responded, now it is not responding, now it has got flared up. In that case, you have to suspect a sarcoptic mange. And the intensity of pruritus is directly related to the number of parasites only at the onset. Only at the beginning of the disease, the intensity of the pruritus and the number of parasites are directly correlated. But later on, instead of the number of parasites, the hypersensitive reactions will take charge and it will lead to more intense clinical signs, especially pruritus, and you will not be able to demonstrate even an organism in later cases. Animal may be itching a lot, but upon skin scrapings, there will not be any organism, but the case may be a sarcoptic mange. So that also you should keep in mind. And another typical test you can do is a pinnal pedal reflex. This is a special test for sarcoptic mange, and literatures are saying that it is positive in more than 80% of sarcoptic mange cases. and rare in other pruritic dermatosis. So the reflex can be assessed by vigorously rubbing the tip of one ear flap onto the base of the ear for 5 seconds. So you can rub vigorously one ear flap towards the base of the ear for 5 seconds, and the pinnal pedal reflex is positive if the ipsilateral hind leg make a scratching movement. So if the animal shows a scratching movement, you can very well tell that the animal is suffering from sarcoptic mange, and this is a very easy and convenient test to detect the mange. And the direct microscopic examination, as I earlier told, the primary lesion most commonly seen is a crusted papule. So best lesion to scrape is a crusted papule, and it is better to search for an ideal lesion rather than scraping any other areas, because the exact lesion, if you scrape, you will get the organism. So look for a crusted papule, you scrape there, and if no crusted papule is found, you can scrape the ear margins till there is capillary bleeding. Then scrape with a used scalpel blade and place the contents onto a slide with a drop of liquid paraffin or mineral oil and examine under a microscope. So hair plucks or skin scrapings can also be used. You can mount in paraffin and examine for eggs, lice, mite, etc. So you can directly pluck the hair, or you can do a skin scrapings also. Tape strips can also be used for sarcoptic mange. Not only for mange, it can be used for lice, you can be used for Malassezia. So in many other conditions, you can use this tape strips. That test also can be employed in sarcoptic mange. In the therapy, selamectin is the ideal compound nowadays. You can use it at 6 mg per kg dose rate. Moxidectin can also be tried at 2.5 mg per kg spot-ons at monthly interval for 3 times. You can use it at monthly intervals. And acaricidal dips. Several acaricidal dips are available nowadays. Twice weekly for a minimum of 6 times can be used. Amitraz is an example. Lime sulfur dips can be used. But they, each compound may differ slightly, and you have to follow the product specifications. For example, amitraz, they may be repeating at a 2-week interval sometimes. So you can go for 2-week interval repetitions 3 times in 2-week intervals you can do, or you can do in weekly twice also. So depending upon the product, slight variations may be there, but generally weekly twice you can apply acaricidal preparations. 6 times minimum you have to apply. Then ivermectin injections can be tried at a dose rate of 400 microgram per kg subcutaneously 3 times at 10-day interval. That's very commonly used, but in coolies it is contraindicated, as you all know. Milbimycin oxime can be tried in such cases at the dose rate of 2 mg per kg body weight orally at 7-day interval. So that is sarcoptic mange. Now another most common condition is demodicosis and demonstration of mites by skin scrapings. So here the number of sites should be more when compared to sarcoptic mange. 3 to 5 sites at least should be selected, and the skin should be squeezed between the thumb and the forefinger, and the area should be moistened with the liquid paraffin before scraping. So there's a slight difference. In sarcoptic mange, you can directly go for ear edges or bony prominences, but in demodicotic mange, at least 3 to 5 sites you have to scrape. That to deep scrapings till the capillary bleeding you have to do, and then you have to examine the scrapings. So mites are more readily demonstrated in demodicosis, unlike in sarcoptic mange, and failure to demonstrate mites from skin scrapings eliminates the diagnosis. So unlike in sarcoptic mange, here even here when the mites are not found in the skin scrapings, you can categorically say that it is negative for demodicosis. But in sarcoptic mange, as I earlier told, even if the scraping is negative, it can be due to hypersensitivity reaction caused by sarcoptic mange. So you have to treat that condition. An examination of hair pluckings or pustular exudate and even biopsy can be used for diagnosis. Even hair pluckings or pustular exudates can also be used, or even biopsy can be used for diagnosis of demodicosis, but these are all not needed in commonly. Usually you will get in deep scrapings. And concurrent factors of demodicosis include malnourished puppies, puppies associated with internal parasitism, and in adults the generalized demodicosis may be seen in conditions like endocrinal imbalances, especially in hypothyroidism, hyperadrenocortism, or corticosteroid therapies, lymphoma, etc. All predisposed to demodicosis. Then localized form of demodicosis can be confused with dermatophytosis, and pustular form resembles the Pyoderma. So demodicosis localized form, as you can see, Here, the picture on the left side with the hyperpigmentation, that is a typical case of demodicosis, localized demodicosis, but that may be confused with the dermatophytosis. So you have to take a deep scraping in every lesion and check for the presence of demodicosis. And the picture on the right side is actually a dermatophyte condition. So that may resemble Pyoderma, but this is a dermatophyte condition. So anyway, you have to do the idea I want to convey is that you should not diagnose a condition, dermatological condition especially, by looking at the clinical signs alone. You have to go for a confirmatory test in each case, then only your treatment will be perfect. Then ivermectin tablets can be given as a treatment of dermatitis, as you all know, 0.4 to 0.6 mg per kg orally every 24 hours and is successful in up to 85% of cases, not in colis. So the tablet form of ivermectin is much more preferred for treating dermatitis at a dose rate of 400 to 600 microgram per kg at daily, and it's successful in up to 85% of the cases. Amitraz dips can be tried, not in Chihuahua breeds and cats you can avoid. Fluralanar, the latest compound marketed as Bravecto, can be tried at a dose rate of 25 to 50 mg per kg body weight orally once in every 3 months that you can try. Moxidectin can be tried at the dose rate of 200 microgram per kg body weight subcutaneously. Then sometimes the demodicosis won't respond in certain resistant cases, or sometimes it will recur very frequently. In such cases, you can use Amitraz at a higher dose. Usually you use Amitraz at a strength of 250 parts per million. But in such cases of recurrent or resistant cases, you can use it at a dose rate of 1000 parts per million on daily or alternate day basis on affected areas. Or you can even give oral ivermectin at a dose rate of 400 to 600 microgram per kg daily up to 8 months. So oral ivermectin therapy is very safe. And here the literatures are saying you can give it up to 8 months. But I don't know whether any veterinarian has given a ivermectin tab for 8 months. But books, literatures are telling that you can give even up to 8 months. And moxidectin also can be orally tried at a dose rate of 200 to 400 microgram per kg daily for up to 6 months. So moxidectin, you can try it for 6 months. Ivermectin orally can be given at a dose rate of 400 to 600 microgram for 8-month period. The next disease condition is Pyoderma. And here the clinical suspicion is the fundamental for diagnosis, because all these organisms, Staphylococcus and Malassezia, are normal commensals of the skin. So a clinically suspicious lesion or a condition should be there for a suspecting a diagnosis of Pyoderma. And cytology is an excellent method to support the clinical diagnosis. You can go for cytology to support your clinical suspicion. And in most cases, the sole agent involved is Staphylococcus specific to the dog, namely Staphylococcus intermedius. So why pyodermas recur in most cases? So most cases of pyodermas are secondary to a definable underlying cause. So unless you treat the underlying cause, there is every chance of recurrence of pyoderma. And while searching in the internet, I found a product called as staphage lysate used in foreign countries. It's an effective and safe treatment for a long-term control of recurrent canine pyoderma. It's made from natural components and it reduces the recurrence by stimulating the immune system. Actually, that products are not, I think it's not available in our country, but you can try for those products in recurrent pyodermas in future. Then regarding the clinical signs, in superficial pyodermas, severe pruritus may be noticed, unlike in deep pyodermas. So superficial pyodermas are more pruritic, whereas deep pyodermas, pain will be more, unlike in superficial pyodermas. And hotspots is a condition of superficial pyoderma. Hotspots are otherwise called as pyotraumatic dermatitis, where there will be very intense pruritus followed by pain. So in that condition, both will be there. Pruritus and pain will be there. But in superficial pyodermas, only pruritus will be there. In deep pyodermas, the pain reaction will be much more than the pruritus. Then regarding the sampling guidelines, in case of fold pyodermas, also called as intertrigose, you can perform an impression smear by pressing the slide against the lesion. You can press the slide at the lesion and then just stain and examine. And in cases of impetigo, folliculitis, and furunculosis, all are superficial pyodermas, look for an intact purulent lesion. Open it gently with the corner of the slide or by a needle. Pinch the skin between the 2 fingers in order to expose the fluid and then apply the slide. So you have to identify the pustule, then you have to open it, then prepare a smear, stain it, and examine. So in case of cellulitis, take the samples under the crust. So furunculosis and cellulitis are all deep pyodermas, so there will be crust will be there on the outer surface. So you have to remove the crust and take samples from beneath. Then only you will get the presence of bacteria, especially Staphylococcus. Stain the slide by fast-acting dyes. For example, Hemacolor rapid staining kits are there by Sigma Aldrich that can be used and it can be examined under oil immersion. And cellular types observed in pyodermas vary. There are different cellular types seen in pyodermas. Not only bacteria, many types of cells can be seen in the smears taken from the pyoderma cases. So degenerate or non-degenerate neutrophils may be present. So neutrophils, either impaired neutrophils or normal neutrophils can be seen, and degenerate neutrophils are lightly stained, as you can see in the picture on the left, and it is more bulky with hyper-segmented and pycnotic nuclei. So the nuclear segmentation will be more, the shape will be erratic. All these things will be seen in the degenerate neutrophils, whereas non-degenerate neutrophils on the right side appear healthy and well stained with a dark purple color. So neutrophils you can see, then bacteria you can see, especially Pookode bacteria suggestive of Staphylococcus, and bacteria may be extracellular or intracellular. Sometimes the bacteria may be seen ingested by a macrophage. So you can see intracellular bacteria also, and macrophages can also be seen. Macrophages and or lymphoplasmocytes may be seen, supporting a more immune response. That means the animal is responding to the immune system is responding to a disease condition, and it is our treatment is actually taking into effect. In such cases, you can see a macrophage and a lymphoplasmocytes in the smear, and RBCs can be seen, especially in the case of bleeding lesions. And lack of bacteria in the presence of many non-degenerate neutrophil can suggest a sterile pustulosis. Especially, you can suspect a dermatophytosis also, where there are many non-degenerate neutrophils with the absence of bacteria. And when occurring with acantholytic epidermal cells and with healthy neutrophils, an autoimmune dermatosis may be suspected in such cases. So when there are acantholytic epidermal cells, means large cells, the acantholytic epidermal cells are very large, polygonal in shape. When these type of cells are seen with healthy neutrophils without any bacteria, you can suspect an autoimmune dermatological disease condition. Then bacterial culture is not necessary in all cases of pyoderma. That is very important. You should not go for a culture in all cases. The cytology of the smears taken from the site is very well sufficient for a definitive diagnosis. But you have to go for a culture in certain conditions when the cytology reveals rod-shaped organisms instead of cocci, or when your antibiotic therapy does not resolve the infection, even though the organism is Staphylococci, or when multiple antibiotic courses are not responding to are not showing any effect on the pyoderma, or when there are non-healing wounds, or when there are potentially life-threatening infections, then you have to go for a culture and sensitivity test, and you have to do it. So the initial prescription of a systemic antibiotic should be for a minimum period of 2 weeks plus 1 to 2 weeks after clinical recovery. So that should be your initial prescription. And if the antibiotic, if the animal is not showing any improvement, the antibiotic should be renewed for courses of 2 more weeks. So you have to renew it for a period of 2 weeks, like that you have to go on. And the best clinical results have been obtained with many antibiotics, but usually we've seen that fluoroquinolones, cephalexin, clindamycin, etc. are showing excellent results. That MRS, methicillin resistant staphylococci, are potentially resistant to many antibiotics, but drugs like fluoroquinolone, ceftriaxone, and tetracyclines are showing good results. And if relapses of pyoderma occur more than every 2 months, treat each infection with a full course of antibiotics. So if it is relapsing at 2-month interval or more than 2-month interval, you have to go for a full course antibiotic therapy. If it is relapsing at less than 2-month interval, you have to go for a full dose week on. Then you can discontinue for a week, and then again you can go for a full dose next week, like that you can go on. Or you can give a full course of antibiotic for a week, discontinue for 2 weeks, then again you give antibiotic for 1 week, then discontinue for 2 weeks. Or you can go for a pulse therapy or a weekend therapy, where you can give antibiotics for 2 to 3 consecutive days in a week. Suppose you can give antibiotics on Monday, Tuesday, and Wednesday, leave that week alone. Then again next week you can give antibiotic on Monday, Tuesday, Wednesday. So like that you can go on. So all these mode of antibiotic administrations can be tried if the relapsing of Pyoderma occurs in less than 2 months. In otherwise, if it is more than 2 months, the full course of antibiotics should be given. Then mupirocin is an excellent anti-staphylococcal compound that can be used externally and is very good in penetrating to inflamed skin. Mupirocin ointments are available in various trade names. And fusidic acid or fusidate is also very effective. That can also be tried. And except for special cases like juvenile cellulitis, the use of corticosteroids is strictly contraindicated in Pyoderma due to chance of severe relapse. You have to properly diagnose the condition and then give a drug. Otherwise, if you are going steroids without a proper diagnosis, this can aggravate the Pyoderma. So next is a superficial Pyoderma called as pyotraumatic dermatitis or hotspots. So it's a skin problem induced by self-inflicted trauma as a result of attempts by the patient to alleviate pain or pruritus. So it's actually a self-inflicted trauma condition by the patient to alleviate the pain or pruritus. And historically, the condition was called as summer eczema. This is nothing but a surface Pyoderma. Although the bacteria may be found in lesions, true hotspots are not skin infections and they do not usually respond to antibacterial therapy alone. So the infection may be there, but more than the infection, the inflammation caused by the infection is predominant in a hotspot. So that is the term itself indicates a hotspot, means it's a highly inflamed area. So anti-inflammatory therapy is much more significant than an antibiotic or an antibacterial therapy. And pyotraumatic dermatitis is very common in dogs, but rare in cats. And the areas most commonly involved are the dorsal and dorsolateral lumbosacral region. As you can see in the picture, it's a dorsolateral lumbosacral region and the perioral region. Means next to the ears also you can see the this thing, hotspot. And affected skin is erythematous, moist, and in majority of cases exudative. So it's mainly exudative also and erythematous also. And diagnosis is generally made on the clinical appearance and history. And impression smears may be appropriate, and you can find bacteria in some type in many cases. And after cleaning and drying, you can apply an antibiotic steroidal combination for 2 to 3 times daily. So only a topical therapy is needed for hotspot, even though the lesion appear very very predominant. The next disease condition is Malassezia dermatitis. So this is an infection caused by Malassezia yeast. So like Staphylococci, they are also a normal commensal, and vast majority of canine infections are associated with non-lipid dependent species of Malassezia pachydermatis. But in a work done by my PG student, it was found that mostly the Malassezia pachydermatis obtained was a lipid dependent type. So maybe in our region, the lipid dependent species may be much more common, but many literatures are telling that a non-lipid dependent species is more common. But Malassezia pachydermatis is the predominant causative agent. And pruritus is always present and it is actually very intense. There will be an offensive rancid grease odor. There will be a musty odor for Malassezia, which will be very predominant, and you can very well diagnose the condition from that odor itself. And an erythematous ceruminous otitis externa. So a predominant otitis externa condition will also be there, and lesions are mainly localized on the ventral aspect of the body. So just like an atopy, the lesions will be similar to a atopy condition. Ears will be affected, ventral neck, abdomen, paws, hind limbs, forelimbs, and the base of the tail region all will be affected. And the clinical signs include otitis externa, pruritus, erythema, rancid musty or yeasty odor, seborrhea, scaling, alopecia, lichenification, hyperpigmentation. So all the classical clinical signs of dermatological disease conditions are usually seen in Malassezia, and clinical signs can be focal or generalized. And commonly affected sites include ears, lips, muzzle, feet, ventral neck, axilla, medial limbs, and the perineal region. So diagnosis, you can do it from the history. There will be a constant pruritus. Then the classical distribution pattern similar to atopy you can see, as I have already told. And cytology is a rapid, reliable, and inexpensive method to diagnose Malassezia. So demonstration of elevated numbers of Malassezia with a good clinical and mycological response to antifungal treatment is highly diagnostic. So you can diagnose Malassezia by taking the impression smears. Along with that, if the case is responding to your antifungal treatment, then you can very well diagnose it as a condition of Malassezia. Then the Malassezia organisms are oval in shape, peanut or snowman shape, and they are usually stained. The impression smears are stained by methylene blue stain, and they will be seen as a blue purple organisms. And the number of V's can be assessed by counting them in 10 successive fields at random under the microscope and identifying a mean of more than 5 E's per high power field was needed for the diagnosis of Malassezia. So in a high power field, the average, the mean number should be more than 5, and you should count at least 10 high power fields nearby, and then you have to, the total should be 50 or more than 50. Then you can diagnose it as a positive case of Malassezia. But Malassezia patchy dermatitis will grow on subrose medium, although the lipid-dependent species require supplemented media such as modified Dixon's agar. So the lipid-dependent species require olive oil supplemented media like SDA or a media like modified Dixon's agar. But the non-lipid-dependent species can grow on plain SDA agar with the chloramphenicol as an antibiotic. Then various sampling techniques, as I already told, direct impression smear and cellophane tape test are the ideal methods for taking the sample. Only thing is that you have to repeatedly take the impression from that site, and tape also you have to 2 or 3 times you have to pluck it and again stick on and then again pluck it, like that you have to do. Then smear from a scraping, just like a Demodicosis or a Sarcoptic mange, can also be tried, and a swab smear, especially in the case of otitis externa, you can try for diagnosing Malassezia. And simple fact of observing Malassezia, whatever their number must be taken into an account for an animal clinically affected with a dermatological disorder. But earlier we are told that we have to count the number of fees and other things, but that is a case where the animal is not suffering from any clinical sign. But if textbooks are saying that if there is a clinical sign, even if there is the number is not at all important. If the animal is showing clinical sign and you are getting even one organism, then you have to go for a treatment. And a small number may cause important clinical consequence in the case of hypersensitivity to yeast. So this small number itself may cause hypersensitive reactions, just like a Sarcoptic mange case. So you have to go for a treatment in such cases. And fungal culture and sensitivity was very useful. Is very useful in very rare or in specific cases only. Actually, the ideal method is cytology only, or impression smears. You can directly, or a acetate tape impression smear can be taken. That is the ideal diagnostic method. There is no need of any culture in SDA agar or in modified Dixon's agar, and there is no actual benefit. But SDA supplemented with antibiotics and olive oil or MDA can be used in certain cases, especially to know the type of the organism that is causing the dermatitis, or especially in order to identify whether the case is responding, assessment of the treatment response you can do. In such cases, you can try for a fungal culture. And sensitivity testing is generally useless also in this case, because they are mostly sensitive to classical antiseptic and antifungal agents. So there is no need to do a sensitivity test, only a fungal culture is enough. Then in my students' PG work, the assessment of response or clinical evaluation was carried out by calculating an MI score, that is Malassezia index score, or a visual analog score for pruritus. The formula is visual analog score for pruritus into 1.8 plus clinical lesion score. So the total of this should come, maximum total will be 90. So visual analog score for pruritus will range from 0 to 10, and that is marked by the owner itself. So that will be a very vague figure. So if it is highly pruritic, the owner can mark it as 10. If it is moderately pruritic, some 5, and no pruritus is there, he can mark it as 0. So that is that into 1.8 plus clinical lesion score will give an idea about the MI score. And clinical lesion score, a clinician will do. The score will range from 0 to 3. You can look for lesions like erythema, greasy scale or exudation, hyperpigmentation, lichenification at various sites. So all these 4 different clinical lesions at 6 different sites can give a maximum score of 72. So clinical lesion score will be a total of 72 plus the previous visual analog score of 18. Thus the total MI score, maximum total MI score will be 90. The animal is highly pleuritic. And depending upon this clinical evaluation parameter, you can assess the progress of treatment response, or you can assess the response of the treatment by a cytological examination also. Mean yeast count you can take from 6 different body sites at different days of treatment, and Malassezia positive cases at least one body site having a mean of more than one yeast organism in an oil immersion field, and you have to count it for a 10 consecutive oil immersion fields. So it's slightly confusing. Only thing is that you have to take scrapings from 6 different sites. You have to keep it under oil immersion field of a microscope. You have to count 10 oil immersion fields, and ultimately the total number of organisms should be either 10 or more than 10 in an oil immersion field. The earlier earlier I have told this type of cytological evaluation in a hyper field. There the average should be more than 5 per hyper field, but here in oil immersion field, if it is more than 1 per yeast organism per oil in an oil immersion field, you can take it as a Malassezia positive case. And same areas should be sampled again on the 14th and 28th days of treatment, and you have to get a reduction of more than 50% for each treatment group, and then you can try assess that the animal is respond to treatment. There is a clinically significant reduction in the number of Malassezia organisms. So when there is more than 50% reduction in the number of Malassezia organisms, you can very well tell that the animal is responding to the treatment. So like that you can assess the response to treatment also. And in that case, in my PG students case, apart from Malassezia dermatitis, patchy dermatitis, Malassezia japonica was also identified on modified Dixon's agar. So that was a species usually seen in human beings, and it was isolated from dogs also. So it's a very rare finding. So various species of Malassezia are nowadays predominant and common. So the management is also very important. And topical and systemic therapy with antifungal agents you can try. Ketoconazole can be given at a dose rate of 5 to 10 mg per kg body weight every 24 hours. Itraconazole, which is very effective nowadays, can be tried at a 5 mg per kg body weight orally every 24 hours. And clinical improvement should be obvious after 7 to 14 days, although treatment should be continued for 7 to 14 days beyond the clinical cure. Here also, the treatment should be continued just like a dermatophytic lesion. It should be continued even after a clinical recovery for 7 to 14 days. In our case also, itraconazole gave a very good 100% response by 14 days in all the cases, but the treatment was continued for 28 days. So the entire treatment period was for 28 days. And griseofulvin, which is active against dermatophytosis, is not active against Malassezia. So you have to go for a azole group of compound like ketoconazole or itraconazole or fluconazole also you can try. Itraconazole 5 to 20 mg per kg can be tried. In our case, we tried only 5 mg per kg body weight once daily. And pulse therapy with itraconazole, that is another interesting finding. That is a dose of 5 mg per kg per day on 2 consecutive days a week, just like a pulse therapy with antibiotics. We are told in Pyoderma, in a relapsing Pyoderma within 2 months, we are told that you can give antibiotics for 3 days in a week. Like that, itraconazole can also be given for 2 days in a week. And the interesting finding is that it is as effective as daily administration of ketoconazole. So this may be due to the persistence of itraconazole in the stratum corneum for a prolonged period, even after discontinuation of therapy. So that is the advantage of itraconazole over ketoconazole. So itraconazole will persist in the stratum corneum and it will be slowly releasing to the body. So even a pulse therapy is effective when compared to the daily dosing of ketoconazole. Moreover, ketoconazole is highly hepatotoxic, so you can prevent the animal from hepatotoxicity also. Then in our work, it was found that neem oil topically was found to be very effective in treating the Malassezia dermatitis. Then assess the animal for a response to treatment at every 15 days. So you have to assess the animal's condition at every 2 weeks or 15 days. If the underlying dermatosis is severe, efficacy can be assessed by yeast counting or by a clinical evaluation. As I earlier told, you can go for a MI score, or you can count the yeast by cytology and you can assess whether the condition is improving or not. But anyway, you have to reassess the condition every 15 days. just like a Pyoderma case. There also you have to review it after 14 days. Then Malassezia patchy dermatitis and Staphylococcus intermedius are very similar and concomitant, means they are almost similar. Both can occur simultaneously in a clinical condition. So they have got a concomitant role in a small animal dermatology. So next disease is flea allergy dermatitis. It's a highly pruritic dermatitis from a hypersensitivity reaction to the flea bite. So that is also a hypersensitivity reaction, and major differential diagnoses include atopy and food reaction. So a canine atopy and a canine adverse food reactions should be the major differential diagnosis, and intermittent exposure to the bite of fleas favor the development of hypersensitivity. So a continuous exposure to fleas is not that much dangerous, but whereas an intermittent exposure to flea, occasional flea bites are more dangerous due to development of hypersensitivity reaction. So that you have to bear in mind. And dogs that are atopic are predisposed to flea allergy. So atopy cases, animals with atopy are highly predisposed to flea allergy also. And flea's saliva contains a number of proteins to which the patient would have been sensitized by prior exposure. So intermittent exposure of fleas are more dangerous, and the hypersensitivity reaction will be more in such cases. And the flea allergy dermatitis treatment, you have to very well. Sometimes the owner may be saying there are no fleas on the animal, but the animal is showing severe pruritus. Then you have to keep in mind that this may be a case of intermittent flea bite reaction. The distribution pattern involves the lower back, especially the dorsal region will be affected, the back region will be affected, and posterior and inner thigh region will be more commonly affected. And a careful examination for both fleas and flea feces must always be undertaken. So a flea comb can be used, and you can brush the animal. You can take the flea dirt onto a moistened paper also, and then you can see whether it is a flea dirt or a foreign material. And demonstration of flea and flea excreta supports the diagnosis, but the absence of those elements do not exclude it, as I earlier told. And 1/3 of confirmed flea allergy dermatitis affected animals showed no evidence of flea or flea feces. So that you should keep in mind. So nearly 33% of 33.33% of cases do not show any flea or flea feces, but the disease condition may be a flea allergy dermatitis. And the gold standard test for diagnosing flea allergy dermatitis is the intradermal skin test with a positive immediate reaction within 10 to 20 minutes, or a delayed reaction within 24 to 48 hours to flea allergens. And in vitro assays for allergen specific IgE antibodies are also available, but they are less specific, and therapeutic trials can be used to confirm a diagnosis. And products available can be grouped into two: insecticides, which kills the fleas, and there are insect growth regulators, which act on other stages of the flea life cycle. So OP compounds, carbamates, permethrins. Permethrins are very effective against fleas with quick killing action, but they should not be used in cats because they are more susceptible to permethrins. And newer products like fipronil, selamectin, imidacloprid, etc. are there, which are very well can be used. But the thing is that the activity is delayed when compared to permethrins. They will kill the fleas very slowly, but permethrins can kill the fleas very quickly. And topical insect growth regulators like methoprin, pyriproxyfen, lufinuron, etc. can be administered as sole agents or as combination products or with a separate adulticide. So this can be used. Many products are nowadays available in the market, like fipronil, methoprin, S-methoprin combinations are there that you can try for flea allergy dermatitis. And the principal problem in trying to control the domestic flea population is the resistant pupa. So pupa can lie dormant for several months and yield viable adults. After all, other eggs, larvae and adults are killed. So the pupa will remain in the environment for a prolonged period. So the environmental products with aerosol sprays consisting of permethrins or with a combination of IGRs like methoprin, pyriproxyfen or cyromazine is ideal, and should treat the immediate surrounding environment also for an effective flea control because the pupa will lie dormant for a prolonged period. So the next condition is canine atopy. So it's characterized by IgE antibody production to environmental allergens, especially inhaled allergens, and it is characterized by inflammatory pruritic skin disease. So studies have shown that the corneocytes of atopic dogs have a greater adherence for Staphylococcus intermedius, and numbers of these organisms are increased in the skin of atopic dogs. So whenever an animal is atopic, the chance of Pyoderma due to Staphylococcus and the chance of Malassezia is also very high. So atopy is a very dangerous condition, and whenever atopy comes, you have to suspect the other two conditions also, namely the Pyoderma and Malassezia. Just like treating a hypocalcemia, you have to give a hypophosphatemia injection, and you have to suspect hypophosphatemia and hypomagnesemia also. Like that, if the animal is atopic, you have to suspect Pyoderma and Malassezia along with the atopy. And the pathogenesis of atopic dermatitis is complex, and newer concepts on the etiology are still emerging. And the clinical signs of atopy include the degree of pruritus may be mild to intense, can be localized or generalized. If localized, specific to one or more of the areas, especially ears, periocular, muzzle, ventral neck, antecubital, axilla, groin, flank, feet, and under the tail, just like a Malassezia distribution pattern. Then diagnosis. The diagnosis of canine atopic dermatitis is based on the characteristic historical and clinical findings with the exclusion of other pruritic conditions. So you have to exclude other pruritic condition, and then you have to take the history and the clinical signs. Then you can arrive at a diagnosis. There is no one specific diagnostic test in ruling atopic dermatitis in or out. So you have to rule out other disease conditions and then reach a consensus in the case of atopy. Intradermal skin testings are there, which will give a positive results in 85% of cases if properly performed. And to prevent inaccurate test results, you have to discontinue steroidal therapy, especially prednisone. Prednisolone should be discontinued 3 weeks prior to testing, and the repository injectable steroid preparations should be discontinued 6 to 8 weeks prior to the intradermal skin testing. Antihistamines should be discontinued 7 to 10 days before the testings. So a lot of precautionary measures you have to do before conducting a intradermal skin test for atopy. The management of atopic dermatitis should be tailored for specific signs, and secondary changes or complications should be treated. Antihistamines, chlorpheniramine maleate, diphenhydramine, hydroxyzine, etc. can be used. They are the three most commonly used drugs nowadays, so that can be used. Then methylprednisolone can also be used at a dose rate of 0.5 to 1 mg per kg in dogs. Induction doses should be given twice daily for 8 days or until remission, and then once daily in the morning for 8 days, and then on alternate. So initially you have to taper the dose, and the dose tapering is approximately 20% every 8 days. So you have to decrease the dose 20% every 8 days to determine the least amount of steroid that you have to give to the animal to keep the animal comfortable. So prednisolone you can give at a dose rate of 0.5 to 1 mg, and then taper it 20% in every 8 days. Then topical immunomodulators preparations like tacrolimus can be tried, and they are very effective as an anti-inflammatory agent. And the advantage is that it can prevent the atrophogenic effects of steroids. Steroids, as you all know, a prolonged steroidal therapy is not good. It is having a lot of side effects. Animal will be showing polyuria, polydipsia, polyphagia. Then immunosuppressive action is there. So all these can be prevented by using a immunomodulator drugs like tacrolimus that you can also try. Then cyclosporin is another immunosuppressive agent. The dose rate is 5 mg per kg orally every 24 hours. The drug does not cause immediate improvement in pruritus, but significant improvement will be seen within 3 weeks. So that is the disadvantage. There is no sudden improvement. Only slowly the animal will improve. By 3 weeks only the animal will start showing improvement, and you have to continue the treatment for at least 6 weeks. Treatment, the improvement will be shown for 6 weeks, and dose reduction as in a steroidal therapy can be tried here also. Just like a steroidal dose reduction, you can try for a dose reduction in cyclosporin also. And MSS is a common side effect. You have to discontinue the cyclosporin therapy whenever there is a renal and liver damage. So you have to go for a serum biochemical estimation of creatinine, ALT, ALP, etc. in order to rule out renal and liver damage. Then cutaneous adverse food reactions can be there, which is very rare, as caused by an abnormal response to an ingested food or an additive. So animal can show allergy to ingested food also, beef, chicken, dairy products, maize, wheat, soya, eggs, all can be allergic to dogs, and the dog can show cutaneous adverse food reactions. So the incidence of adverse food reaction is controversial and difficult to determine as it may coexist with atopy. So this also can be seen along with atopy. So it is very difficult to pinpoint this as a case of cutaneous adverse food reaction. And the clinical signs are almost similar to atopy. Pruritus is the most common clinical sign. It is usually non-seasonal, although dogs with atopy may be showing seasonal occurrence of clinical signs. Flea allergy also may be seasonal, whereas in food allergy, the pruritus will be non-seasonal. Then cutaneous adverse food reactions can cause gastrointestinal side effects like soft feces, flatulence, intermittent diarrhea, and colitis. So these type of gastrointestinal signs will also be shown by the animal, and the definitive diagnosis you can reach by giving a restricted diet feeding, especially to animals composed of unique ingredients to which the animal has never exposed. So a type of hypoallergenic diet can be tried in this case, and it's critically important to obtain a full dietary history also. So hypoallergenic diet means proteins have been hydrolyzed to reduce their molecular weight to less than 10 kilodalton theoretically, rendering them non-immunogenic. So the molecular size of the protein, so not molecular weight of the protein is decreased to less than 10 kilodalton so that it is not immunogenic. So such type of diets you can try, and they are more expensive. You can the least expensive ones are single protein diets, but the ideal one is a hypoallergenic diet itself. Single protein diets are more palatable, but the more ideal thing is a hypoallergenic diet. And any animal that improves with a restricted diet can be challenged with the original diet. One by one, you can introduce the original dietary ingredients, and you can look for the presence of pruritus. And if it is so, you can identify the specific agent causing food allergy. If a CFR is involved, there will be an increase in the pruritus within 7 to 10 days of the dietary challenge. So it's a time-consuming process, and it's very difficult to diagnose the condition also. And lastly, one condition which I came across in the clinics hospital where I was working. So I thought to share with that. It was a very, I think it's not so common. It's a feline skin fragility syndrome, where the skin of the cat was found to be extremely fragile and thin skin, and associated with hyperadrenocortism, diabetes mellitus, and excessive use of progesterone. So a 3-year-old cat was presented with alopecia, especially rat tail appearance was there, wound was there, and it was found that the skin was extremely thin and elastic. Here the one lesion you can see, that lesion was was found on the animal at the time of presentation. So a glucose check was done by the glucometer, and it showed that the glucose level was very high, nearly 300 milligram percentage. So the animal was suspected to be either suffering from hyperadrenocortism or diabetes. So we sent a blood sample for checking the cortisol level. It was found to be normal, and the skin sample was taken for a biopsy, and it shows that the dermal collagen showed thinning, fragmentation, and irregularly arranged with increased spaces between the bundles. So the condition was identified as feline skin fragility syndrome due to diabetes, and the animal was treated with hypoglycemic agent glipizide. Actually, Glide was the trade name. Used 5 mg was given to the cat, half twice daily orally. Amoxicillin clavulanic acid as an antibiotic was also given to prevent secondary bacterial infections. Multivitamin drops were also given, betadine solution, and now laser treatment is because the animal was improvement was shown, marked improvement was shown, the hair growth started, but still the tip of the tail had some lesion. So we are now undergoing employing laser treatment for unhealed wounds, and animal has improved a lot. So this type of cases are also rarely coming to our clinics. So just shared this interesting case. So that's all for today. I am winding up this session. So once again, I am thanking each and every one of you for patient hearing. And I thank the organizers for giving me an opportunity. Thank you.
Thank you, sir, for taking us into the diagnostic as well as treatment aspects of dermatology. I think many of my colleagues are still down, typing down the questions, but to start with, we have received a few. Kindly elaborate once again on pulse therapy. What is pulse therapy as per a clinician?
Pulse therapy is nothing but you can give a drug, especially steroids can be given, or an antibiotic can be given, or an antifungal agent can also be given. But there is no need to give it in a daily dosing regime. You can give it 2 or 3 days a week and then discontinue it for that particular week. Then again, during the next week, you can give it for 2 to 3 days, like that. That you can try only after only in suppose in Pyoderma, you can try it in recurrent Pyodermas within 2 months. Or in Malassezia, you can try it with itraconazole. Certain drugs you can try. Steroids also you can try it in a higher means elevated therapeutic concentration. You can try this pulse therapy in certain conditions. So in special conditions, you can try this pulse therapy. Not in all conditions. Where in Pyoderma, you can try it in recurrent cases where the conditions are not responding within 2 months. With antifungal treatment with itraconazole, you can try this pulse therapy. And also with steroids, you can try in certain disease conditions where a prolonged steroid therapy is essential. You can try this pulse therapy. But it's not a regular practice. You can try it in cases which is not responding to specific disease conditions.
Right, sir. The next question is from Dr. Raviray Durg from Shimoga. Could you just enlighten us on the treatment of anal frunculosis?
Anal frunculosis, okay. So this type of conditions are very difficult to cure all on a sudden. The fistulas will be draining. There will be a blind and open drain will be there towards the anal region. Then another blind opening will be there. So the pus will be retained in the blind space. So you can go for a routine antibiotic, antiseptic therapies can be tried. Then you can surgical techniques, opening the fistula and draining the pus can be tried in some conditions, or even this laser therapy, which I tried for this skin fragility syndrome, can be tried, or cryotherapy, but very difficult to get a cure. Prolonged treatment may be necessary. This is a frunculosis, is a deep pyoderma condition, just like a cellulitis. So prolonged therapy of 4 to 6 weeks of antibiotic combined with the surgical techniques along with the topical antibiotic or antiseptic flushing of that region, flushing of that fistulas, all can be tried, and you may get response upon a prolonged treatment. At least 2-month therapy sometimes you may need.
So the next question is when to use a topical therapy and when to rely on a systemic or a parenteral or a oral therapy.
I think depending upon the severity of the lesion, you can a clinician can judge whether you have to go for a topical therapy or a systemic therapy. Many a times a combination is ideal, topical along with systemic. But if the condition is such a way that only topical is needed, you can try that initially. And if the case is not responding, you can combine it with a systemic therapy. That all depends upon the type of the lesion and the age of the animal, the financial status also you have to take into, because systemically if you are giving an antibiotic for 2 months, that will be costly. So, but in some conditions that will be necessary, especially in Pyoderma and other things. So depending upon many factors, you have to judge whether it's a topical treatment is depending on the condition. So suppose if it's a pyotraumatic dermatitis or a hotspot, even a topical therapy may work, but in a deep pyoderma, topical therapy may not work. You have to combine it with systemic agents. So it all depends upon the condition, age of the animal, financial status, everything will be a factor. So you have to judge based on each condition. There is no hard and fast rule.
Right, sir. We've not touched on this topic, but one of the viewers has asked about skin cancers in dogs. So
yeah,
in case you can touch it.
yeah, neoplastic conditions are also very common, especially mast cell tumors are very common in dogs. Then squamous cell carcinomas can also be there. So this type of biopsy is the ideal diagnostic techniques for carcinomas. The lesions will not be pruritic. There will be nodular type of, means tumor type of elevated type of lesions will be there. Then you have to take a biopsy, especially from the periphery. You have to do a histopathology, look for the presence of neoplastic cells, and you have to go, give an anti-neoplastic treatment. Means a chemotherapy schedule can be tried. With many agents are there that you can employ. But in muscle tumors, you can go for an antihistamine therapy with many agents, chlorophenamine, maleate, etc. can be tried. But I think a prolonged therapy will be, I think Nagaran sir may be having more experience with me. Sir can add a few things, I think.
Sir, over to you.
Yeah, actually, anti-neoplastic therapy is so important. It all depends upon the severity of the lesion. See, if the severity mast cell is very serious disease, we cannot. The surgery is the only thing. In the surgery, they are going for excision of the area. That too, in the early stage, they have to do it, and they will give 2 centimeter away from the lesion, and then they will remove it like that. We have got histiocytomas, lot of histiocytomas, which is benign. That is also commonly seen. And we have got lot of TVT. TVT also very commonly seen as a thing that is responding for vincristine and other thing. So we can we have to try anti-neoplastic and see whether it has got any, even a sweat gland adenocarcinoma can be a serious thing. It may be seems to be local, but easily it will spread. Sometime it will be in inflammatory type, means it will be recurring. And if it is going to enter into the lymph node, then it will be a problem. So it'll even if you are going to remove, it will reoccur. Particularly in cat, we have seen a lot of cases of sweat gland carcinoma. So like that, we have to try in different means like radiation. It is not at all practiced nowadays. Only few areas they have gone for radiation. But as in human, if you are going to do with the anti-neoplastic radiation together or a surgical everything combination, then it will be better. So that will the outcome will be better, and it should be earlier. The presentation of the case should be earlier. Then only we can easily go for it.
Right, sir. The next question is, sir, it's just a quick clarification. You have talked about ivermectin using for 8 months. So is it injectable or oral? I think it is oral. So
Oral.
yeah.
Oral.
Now I think people are touching on topics which Dr. David had not touched on, like hypothyroidism and all. So we'll not touch on all those because we don't want to conclude the entire dermatology today. So with that, we come to the end of this session. I think the last question is, sir, is there no side effects of using antibiotics continuously for months together? Probably yes, there are, but at times in Pyoderma, it is a need to do that. So I give that as a last question to Dr. David, and then we conclude on it.
Yes, there are side effects definitely, but you have to, sometimes we will be in a position to treat those conditions for a prolonged period. Otherwise, the animal may not be responding. So safer antibiotics can be tried, and you have to continuously monitor whether the vital organs are working properly. So a routine blood checkup or a routine assessment of the condition of the animal you have to do. Don't give it at a stretch for 2 months. You can give it for 2 weeks, then ask the owner to bring back the animal, check the blood values, check the condition of the animal. Clinically, you evaluate the animal and hematologically examine the animal. Also, serum biochemical parameters you examine, and then prolong the treatment. Don't blindly put it on an antibiotic course for 2 months, and something happens now, there will be a problem. But you can monitor and you can very well continue the therapy for 2 months. No problem in that way. But anyway, side effects are there. Side effects are there for every drug, not only antibiotics. Many other drugs are having side effects. So carefully you can move forward.
I think that brings us to the end of the session. If Dr. Nagaraj has to add on something, being a clinician. We on behalf of the entire AVD group and INTAS thank each and every participant. We had today close to 1000 participants. So after a long gap, we are back to normal. We are approaching a better clientele. So thank you all the clinicians, all the veterinarians, all the academicians and students, postgraduate students, and all people who are being a part of this program. Thank you to all. Thank you, sir. Thank you for being there.
Thank you, sir. Thank you very much. Thank you all.